Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we got a great guest on the program, David Bradshaw. He is an executive advisor. Welcome to the program, David.
Hey, Tom. Thanks to hook up with you again, man.
Yeah, a little bit of background. David used to be my boss at Cerner, so my boss's boss actually. So it was always a pleasure speaking to you. Although I probably frustrated you a lot, so that's another story. But anyway,
never a frustration, man. Your passion, your drive was always right on, man.
Oh, I appreciate that. So, David, tell the audience a little bit about yourself and your passion in healthcare.
Yeah, right on, Tom. So, man, I started this effort into the industry graduating from college. Was recruited by IBM and sent to Shreveport, Louisiana. And I was the new kid in the branch office with a new car. And they said, hey, you get to cover all the hospitals north of Baton Rouge. And that was my territory. So from Alexandria to Ruston to Monroe to Shreveport. And that was my introduction to healthcare. And I've never left. So IBM moved me Shreveport to Dallas on the area staff and down to Houston. I had married a native Houstonian that I met at Texas A&M, and so we were kind of coming back to her hood, if you will, and was there and recruited by the CFO at Memorial Hermann right after the merger to be the CIO, and it's kind of a big jump for where I was to the CIO, but that job lasted 20 years. The last 7 of that, I was also the chief strategy officer, so the EVP and chief strategy officer. And it was interesting. I had marketing, I had the ACO, the health plan, a lot of different business functions. And after that run, went to Cerner, where you and I hooked up, was SVP there and had a couple of different business units. And about the time Oracle was getting sights on Cerner, they had a program for guys like me that have been around the industry for a long time to leave. And so I left Kansas City, came back to Houston, and now am working in a small advisory firm, still very active in this industry because I think this is a better time to be at the intersection of technology and healthcare operations than any time in the past decades, man.
I couldn't agree more. And you know what I love about your background is you come at it from a hospital perspective, a delivery of care perspective. Certainly, a lot of things are happening in the health IT space, and hence Cerner gave you the charge there, and you're also now very involved in the investment space. So yep. I appreciate that. What are one of those things that, you know, in the context of things that you're engaged in that kind of draw your attention?
You know, Tom, it's actually something I learned at Cerner. When I was at Hermann, we weren't really into the DevOps methodology, but Cerner was really big agile shop. So design, build, test, run, operate, that whole kind of life cycle. And so I got a lot of exposure to that. And now that I come back kind of in this advisory capacity, we're engaged with a lot of primary care groups, physician organizations, hospital systems that, you know, have ACOs. And I always ask them, what's their equivalent to DevOps? And I call it CareOps. And there's actually a movement around care operations. There's a couple of websites out there. I follow one called CareOps.org. And it really is applying those DevOps principles into the clinical practice. I think in our hospitals, we've been high reliability. We've been really focused on process a ton. But when you think about the patient navigating into the healthcare system and navigating themselves around the healthcare system, it's still pretty fragmented and hodgepodge. And that's a big area that I'm focused on right now is how do we bring that CareOps mentality into patient engagement, pre-visit, post-visit, and what I'll call in-between visits.
Yeah, it's actually an interesting term. I actually got a newsletter just this morning talking about CareOps. So that's not a so I know in my experience we get involved in obviously making sure that the workflows are synchronized and things of that nature, but nothing's ever perfect. But so can you tell me a little bit more about what is CareOps? It's obviously a new term. I'm curious to hear from my audience as well when this gets posted, what their engagement level is in this term and this methodology. So let's key on that for this conversation. What is CareOps?
Yeah, so just think about, the equivalent of how we would do that in DevOps. So we would, if we were in the CareOps world, we would sit down with some clinical experts. We would sit down with some process type engineers. We would have clearly some medical oversight, maybe a design principled person, and we would think about how we are building this patient flow. I'll call it a care flow. That's kind of a common term that's starting to be
Right.
out there. And how do we put all the disciplines around this notion of what are we going to design with intentionality? So we're just not going to let patients wander in the ether out there pre-visit or post-visit. We're actually going to design a process. We're going to design a series of steps, and then we're going to build that in our tech. I think there's a ton of work going on in these, I'll call them PE-backed digital innovators, where they've got product teams and digital, and they're building their own tech. And they're building these processes and these automation tools that are multi-channel. And so I say multi-channel, they're using a portal, they're using texting, they're using maybe phone calling, maybe they've got a conversational agent making phone calls, they're pushing forms. And the equivalent of that, what I observe in these not-for-profits and the ACOs, is a bunch of siloed independent tools because they tend to purchase things. So I think the PE firms are building these integrated CareOps platforms, and these ACOs and the not-for-profits, they've got a lot of tools that tend to create channel silos. And their challenge, in my view, Tom, is how do they really put together an experience across those various channels?
Yes, I would agree. Well, as well as I, healthcare in and of itself is very siloed, right? We all have the same end, but we all do things differently. In New Jersey, where I once lived for over 50 years, in Mercer County, there's 3 hospitals, right? Then you can pick which hospital you go to. So every hospital does something different, right? And so instead of working collaboratively across hospital systems, so there's some commonality, some standards as to what the delivery of care is, depending on the hospital you go to, or even the ambulatory provider that's helping serve you. Everything's different, and I know it's even a challenge right now with my mother-in-law who's going through some challenges, and it just when you're outside the brick and mortar, it's an open field relative to what do I do next and how do I get care, right?
Yeah, and I would say that from a strategy standpoint, the concept of standalone hospitals, unless you're a specialty hospital, children's cancer usually are the two, maybe orthopedics. But if you're a standalone hospital, you're usually part of a clinically integrated network, a CIN, we'll call it. And the government's given us lots of different programs to knit together all the different pieces that we need to in a CIN, clinically integrated network. And my contest would be that patients shouldn't get lost in clinically integrated networks. We should know who hadn't had their annual wellness visit. We should be having programs to get those patients in to their primary care doctors. When we have patients that are getting discharged from a hospital, they shouldn't have to worry about where their follow-up visit is or whether they're going to the CHF clinic or not. We need to hardwire those processes inside of that CIN. Because let me tell you, if they're taking risk, they got to do it. If they're trying to grow their fee-for-service revenue, they've got to do it. And that's the franchise that they tend to own in those communities. And it's a shame when we see lost opportunities to really build those connected flows across the different disciplines of that clinically integrated network.
Yeah. So David, tell me a little bit about CareOps in the context of its methodology. It sounds like there's a predefined methodology with phases, and what does the tech company do in that methodology, and what does the hospital or ambulatory provider do in the execution of that methodology?
Yeah, good question, Tom. So I think people use a lot of words to describe different steps. I'm gonna use 6. So design. So how do we, as a multifaceted group of people, sit down and design a care flow? Build it. How do we build it in the tools and the text using the different channels? How do we test it? What works, what doesn't? How do we run it? So now we're running this thing at scale. And then how do we measure it? And hopefully we've built into the design instrumentation to measure what's the most effective way to convince patients, let's say, that didn't pick up their prescriptions to go pick them up. Is it a phone call? Is it a text? Is it a conversational bot reminding them? Is it an avatar of their doctor delivered in a text? I mean, that's the concept of A/B testing. So how do we measure? And then the last step, how do we improve? So 6 simple steps: design, build, test, run, measure, and improve. And I think those were actually the steps we used at Cerner in our agile process.
Pretty much.
And that's why I'm trying to think about this and apply it now to CareOps.
Interesting. So, I know relative to the delivery of care side of the equation, we in our industry, specifically virtual care, where I have been most focused in the last couple of years, we talk about, you often hear about, hey, I can increase medication adherence, I can reduce emergency room visits, I can reduce hospitalizations. They're all good things, but I still have diabetes. I'm still obese. I still have a cardio issue, right? When you talk about measures and outcomes, to me, I don't think we tend to focus on it in the context of a payer versus the context of the patient, right? Increasing medication adherence, reducing emergency room visits, hospitalizations, they're all good value-based care efforts, but I'm still sick, right? And we have more folks, as you know, today with diabetes than yesterday. So then to pick a chronic condition, the number is greater today than yesterday. So I think it sounds like CareOps can do a lot relative to a bit more, not only focus on the solution, the technology side of the house, but how do we standardize potentially on the delivery of care and make sure that the patient is at the center of care and not a payer network?
Yeah, well,
Thoughts?
Yeah. So, I think that my clinical colleagues that I've worked with for the years would expect me to say this, that, ultimately, chronic lifestyle challenges are owned by the patient.
Yeah.
So if you're obese and you want to become less obese, there are ways to do that. And there's no doctor, there's no CareOps that's going to accomplish that goal for the patient. Now, maybe a prescription of Ozempic would help.
Yes, it's true.
But again, it comes down to patient compliance because, and I do think as our country, we're going to have a big problem when these people come off of Ozempic and we're going to see their weight come back. But that's a whole separate topic. But what CareOps is trying to do is when you're discharged from your primary care doctor and you're a newly described diabetic, and you've been told you're obese and you need to do these 3 or 4 things to improve your life. What is the model that primary care practice has put in place? What is their care flow for newly diabetic obese patients? What do they do?
Yeah.
And
and the same thing holds true for, okay, you're a diabetic, newly diagnosed. That's, to me, how do I remotely monitor you? How do I help you manage your chronic care condition? Because to your point, I know you have a history, not you personally, but in your family you have a diabetes. You know the story about my father, and
Yep.
so does the audience. So the point there being is that I said this at UPMC when I presented at their Connected Health event, and I said it doesn't matter what happens in the brick and mortar. What's important is what happens when you're outside of the brick and mortar. And my context to that was, and my audience has heard this before, the average Medicare patient with 5 chronic conditions sees 9 different doctors, only in front of their doctor 15 hours in a given year. That's a CMS stat. What happens the other 8,745 hours? That's important.
Well,
Because that's where, to your point, that's where the patient has to be compliant with something. But ultimately, if they are not guided, they're back in KFC eating Kentucky Fried Chicken.
So I like the way you talk, Tom. So, first, I would say let's go back to your analogy. A newly diagnosed diabetic that is obese, and they've been sent out back into the wild. Let's say maybe they got a pamphlet. Maybe they're going to be motivated and they're going to do a little bit of web research. But what CareOps is about is bringing the clinicians, the tech people together and saying, okay, we're not going to let our patients just wander around in the wild. So we're going to have a care manager call them and introduce them to this diabetic management program. And you talked about RPM. Well, we can't RPM every patient. I mean, there's just not enough money in the system to do that. But there are some that clinic condition meet that and some that clinically don't meet that. And so
I agree.
CareOps model is designing the flows that, okay, everybody that's got a reading of this and an obesity level of that, we're going to put them on a care management program and do RPM, and we're going to get their weights daily. But these other people, maybe we're going to set up in our care flow that we're going to have one of these new conversational agents call them every week or every 2 weeks and just ask them, have they been weighing themselves regularly and have they seen a sharp increase in their weight? Maybe that is good enough for some of that segment, but we start to really build care flows and then we get the machine, the software running, and patients are moving through these care flows, and we should be seeing that come back to us on a dashboard. So if we've got 50 newly diagnosed diabetics, and we're seeing good engagement on 30 of them, and 20 of them, haven't responded to anything. They haven't filled out any of the post-visit forms. We have no engagement from them. Then we need to step it up on those remaining 20. And so that really kind of comes to the measure piece of, can we measure our populations then that are on these different care flows?
Yeah, I couldn't agree with you more. And I think this is, now that I understand a little bit more about CareOps, a distinguishing factor in whether you're a hospital or an ambulatory provider or specialist with an independent practice, if your health IT vendor isn't talking to you about care operations, those care flows, as to how their technology is deployed, then I submit to you, and certainly challenge me if you think I'm wrong, I would submit that they should move on. They should probably move to another vendor or talk to somebody. And here's the reason why. At the end of the day, providers need help, right? They are just we have a older, ager, sicker population, less doctors and nurses. That's really the macro trends that we're dealing with, and growing. So we have sicker in the context of more and more people have chronic conditions. So we've already talked about that. The question is, how does technology, because technology in and of itself doesn't help me. It has to have a flow to it, or it's got to be supportive of something associated with the delivery of care. Thoughts on that?
Yeah, well, I mean, I think you're describing in a way what I'm trying to represent as a care flow, which is a workflow tool for the patient. And Tom, you and I actually we've been down this road before. So when we were at Cerner, we had one of those big pop health systems called Healthy Intent, and we could see all these patients in the registry that needed an annual wellness visit. We could get lists from the payers of all these patients that didn't pick up their meds, that the payers wanted us to go chase to find out why they didn't pick up their meds. So there's tons of lists out there. And you and I, and our whole team, we were working with one of these big CRM vendors. I'm not going to say their name. I think we can figure out who that was. And we had this concept of patient journeys. And we were going to build these patient journeys where we were going to go engage these populations that needed to take action. And what we really found was that was like a bazooka shooting a fly. Super expensive, always required $1 million almost of a SI. And at the end of the day, basically what we did is we were emailing them. And we could figure out if they opened the email, then we'd send them a different email. And I think that we're seeing the emergence of some new tools now that are healthcare specific. And one that I've been working with and following a little bit is this company from Brussels, from Europe, called Awell, Awell, not to be confused with Amwell. But they really provide like a design studio where you can start to build these care flows. And they may sit on top of your existing texting platform. They may sit on your patient portal. These new wave EMRs, these new age EMRs that are API first, there's lots of exchange back and forth between these EMRs. And so we're really starting to see the platform capability to power these design and build of these care flows.
Interesting. Yeah, I agree. We're on the exact same page, and I think this is all about how do we help personalize to some degree that patient engagement. It's to me, it's all about patient engagement because and some patients engage more than others. To your point earlier, right? We have to find, as I used to coach. I used to say, I have to coach the least best person on the team just as much as I have to coach the best person on the team. And if I can do that equally, I can raise everybody up as opposed to just focusing on the best player, right?
Yep.
There's 9 people on a baseball team. They all have to field the ball, right?
Yep.
So not hoping that they're not always going to hit at the third base. The ability to implement these care flows where they are highly engaging of patients for the betterment of the overall outcomes of that patient and that delivery of care model is.
And using the different channels that are at the clinic's disposal. And when I say channels, right, your care managers, your nurses, they're a channel. They're probably the highest cost channel. You've got portals and portal messaging. That's a channel. I bet you've got a texting platform. If you don't, you're probably going to get one. You've got forms that you're trying to push out, electronic forms that you're trying to push out and have the patient fill out. I think there's this whole emerging of this conversational voice. I've heard some of these things that sound almost like human.
Yeah.
And we've actually been working with texting on annual wellness visits. And we found that both channels, texting and conversational voice, had about the same lift in getting patients in for annual wellness visits. And hey, some people, call it tomato. Some people call it tomato.
Yeah.
And who are we to say this is the channel but that's the experimentation. That's the measure phase when you've got these cross-channel platforms that you can start to use and design in your care operational model.
Yeah, be all inclusive. I get very frustrated when someone says that doesn't work or that doesn't work. And I always say, as soon as you discount that, it might not work for 100% of the folks, but it'll work for 20%. So if you so you have to include it, because as soon as you exclude it, then you're taking away 20% of your network, right? And for a healthy quality, everybody's included, right? So we just have to find that best path to that between the doctor's office and the patient relative to what's best for them and how they like to engage to improve, to get to the goals that were set for the team.
Exactly. It's a combination of testing and probing and learning fast and adjusting on the fly. And, these new models, you can't run to IT every time because we know what IT's like. They're worried about the next cyber.
No, I don't know. What are they like?
They're worried about the next cyber event. They're worried about the Epic conversion or the Cerner new version.
Exactly.
You know what that's like, man.
Exactly. So, David, we have 2 minutes left. Great conversation on CareOps. Very educational. Close out the show on what you think the audience should do now that they've heard a little bit more about this term and this methodology.
I would. My advice would be go spend some time in a clinic. Go find the director of care management that's got 20 care managers working for her or him, and just observe what they do every day and how they're doing these patient chasing activities. Because once you spend some time in that office and really understand it, you'll be able to start to apply design thinking to that. And you'll have tools in the shop today that you can start to bring to solve that problem and really get to your point of, no patient should be discharged into the wild, wild west, man.
Exactly.
They're all discharged with a plan.
Yeah, I agree. David, it was an absolute pleasure to see you again, talk to you. Very informative. I hope the audience thinks the same way. And I want to thank you for coming onto the program. You did mention a website earlier. I think it was careops.org.
Yep.
Did I get it right?
Yep,
so if folks want to learn more about CareOps, careops.org. And certainly David's available on LinkedIn if they want to reach out and touch you and talk to you directly. So hey, again, thanks for your participation. Very much appreciate it. Have a great day.
Bye-bye.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, TheVirtualShift. I'm Tom Foley. Until the next shift.